centimeter length with a 14 French size with tapering end. And this is a LA guide wire. It's around 180 centimeters in length with 0.025 stainless steel wire with a coil floppy tip. That's more traumatic. Actually, LA wire sometimes can cause traumatic, so careful handling is to be needed. Coming to the main part, the balloon, there are different makeouts of the balloon. The most commonly used balloon available right now is the Acura balloon, and the old balloon is the Torre made manufacturing Innova balloon. Other balloons available are SIM PBMV balloon made by Life Tech Sciences and the Synergy balloon made by Advanced Life Sciences, New Delhi. The balloon size reference diameter is height in centimeter by 10 plus 10. That's the Hung's formula we use to calculate the balloon. And these are the differences between the commonly available balloon, that is the Acura balloon and the Innova balloon. Coming to the differences, the major difference will be at the proximal end. In Acura balloon, the proximal end will be having only 2 hubs, whereas Innova balloon will be having 3 hubs. So there is additional safety mechanism with the Innova balloon. So especially when we have a difficulty in deflating the balloon, after inflating, when the balloon got stuck in the mitral valve, so this additional stopcock or the vent mechanism helps us to de-air the contrast. That's one additional benefit with the Innova balloon. So that we call it has a separate connector called as W connector. Whereas with Acura balloon, it has only 2 ports. And the other difference between Acura and Innova balloon is the Innova balloon has additional 2 small holes on the balloon, so that sometimes if the contrast dilution is on the higher, if the contrast dilution is on the lesser side, and if the balloon gets struck up through the small holes, the contrast slowly seeps over and it helps in deflating the balloon. So Innova balloon has additional safety mechanisms, 2 safety mechanisms. One is at the proximal safety hub and the other is small holes on the balloon. And the disadvantage with the Innova balloon is because of these small holes, the blood will enter into small holes and it forms a nidus for the, when we want to reuse the balloon for the separate again procedures, it can cause infections. So some details about the basic details about the balloon. Innova balloon is a dumbbell shaped balloon that self positions in the mitral wall because of the unique physical properties and the mode of inflation. The basic feature of Innova balloon is it self positions in the mitral wall. It has 2 latex layers with a nylon mesh in between, giving the balloon its unique shape with inflation characteristics. The shaft of the balloon is 12 French coaxial double lumen catheter made of PVC. There are 2 small holes in the balloon that allow the slow seepage of contrast in case of deflation failure. And coming to the measurements, the uninflated balloon will be around 25 millimeters, and when we inflate the balloon completely, the balloon will be having a 45 millimeters length, 25 to 45 millimeters, the length will be. And coming to the inflation, the distal end of the balloon inflates first, followed by the proximal half, and later followed by the constriction across the valve. Because of the unique physical properties of the balloon sequentially dilates. First the distal, followed by proximal, then followed by the middle constricting rim. So this is the balloon this is the table showing the difference between the 2 available balloons, Acura and Innova. Generally the Acura balloons which we use regularly, that is 11 French size with a length of 80 centimeters with 2 proximal ports, and the problem is it doesn't have any safety vent or it doesn't have any small holes. And the commonly available sizes are Acura balloon will be having a range of 3 centimeters, 21 to 24, 23 to 26 and 25 to 28, a range of 3 millimeters, range of 3 millimeters. Whereas Innova balloon will be having a range of 2 millimeters and the available sizes will be from 24 to 30. For pediatric age group we go with 26, 24 and for the adults we go with 28 and 30. So this is the Acura balloon and the hub will be having the number will denote the higher number, the maximum balloon inflation size. And this is the balloon stretching metallic tube, it will be having 80 centimeter length with 0.032 size. And this is till now our operators have explained about the how to assemble the balloon and the metallic tube. First, common thing to remember is gold and silver go hand in hand. First gold and silver, then followed by the plastic metallic tube. So this is the LV entry shielded. This is a J-tip shielded with length of 80 centimeters and the size is 0.038. This is the tip of the broken bone needle. Coming to the syringe, it has 30 ml capacity. Generally for a 26 balloon, the ratio will be like 1 ml is equal to 1 centimeter. 1 ml is equal to 1 millimeter inflation for a 26 balloon. Coming to even there's a point regarding the how to fill the syringe. While filling the syringe with the contrast, we should make sure that the contrast fills up to the base, not to the tip. This is the caliper to measure the balloon size. Thank you, sir.
What's the dilution of contrast you use? We use 1:4. It's different for both. Dole it is 1:4. For Acura, because the difficulty in extraction, there is no safety mechanism, they say 1:9. But whatever your fluoro shows, it should be thick enough to visualize the it. But it's more than 1.4 is to 1.5, 1:5 minimum. Some books say 1:9. For Acura. Some books say 1:9.
Now we'll have a 5 minutes tea break, sir, and we'll gather fast again and we'll join for the live case.
Timely reminder.
చాలా కామన్ ఆర్మీలో అక్రాస్ ఆర్మీలో ఎక్కడ డైలైట్ చేసుకోండి బాగా చేసామని ఫీల్ అయ్యి చాలా కామన్. ప్రణవ్
Doctor?
Welcome back. Now I request Dr. N.S. Ramaraju sir to enlighten us about transeptal puncture.
Good evening, everyone. The topic allotted to me is regarding the transeptal puncture, which is very much vital for any structural heart interventions, especially mitral valvotomy. And before going to the transeptal punctures, we have to understand the anatomy of the intra-atrial septum. Then only we will be confidently puncturing the intra-atrial septum. So the objectives of the present talk is give a brief history of the transeptal catheterization and review of the anatomy of the intra-atrial septum, and discuss the indications and tools for transeptal catheterization, and review common fluoroscopic and echocardiac techniques for transeptal puncture, and to discuss the new technologies for transeptal puncture, and review and management of the complications in the TSP. Coming to the transeptal catheterization, the transeptal catheterized puncture started way back in 1959 when LA pressure measurements, it was done to measure the LA pressures. Later, in 1984, after the evolution of pulmonary mitral valvotomy, people started gaining expertise in transeptal punctures to do PBMVs. Later, EP technique. Later, EP techniques taken over with pulmonary vein isolation, left atrial appendage closure, percutaneous LV assisted device, suppose there is an associated aortic valve disease, transcatheter mitral valve replacement, transcatheter mitral valve repair, and in the mitral paravalvular leak closures, transeptal puncture is indicated. Regarding the development of the atrial septum, in a single slide, I want to show that initially the septum primum, it starts as an envelope from the left atrium, grows down towards the endocardial cushions, and later septum secundum forms. And the area at the lower part of the septum secundum will be the fossa ovalis. Coming to this is the anatomical view of the heart. This is called as a surgeon's view. Suppose if you open the right atrium and see the heart from the anteroposterior view, you can see the right atrium is intra-atrial septum is not a single structure as such, because intra-atrial septal surface is a very much thin area, very much small area, but beyond that the entire intra-atrial septum will be surrounded by important structures like aorta, superior vena cava, inferior vena cava, tricuspid valve, and somewhat posterior valves. So very limited area will be there, and that is the fossa ovalis, which is the target for septal puncture. So this is how the anatomy looks. The intra-atrial septum superiorly connected to superior vena cava, inferior to inferior vena cava, and antero-inferiorly the tricuspid valve, and superiorly the aorta will form an indentation in the right atrium. And fossa ovalis is the area, and which is usually in the most posterior part of the intra-atrial septum. The true intra-atrial septum occupies only a small part of the atrial wall and can be described more as a septal surface. You can see in this diagram, the pointer is not working. So the fossa ovalis will be in the very much posterior aspect of the intra-atrial septum, and it is a very small area. Inferiorly will be the tricuspid valve, and superiorly, antero-superiorly will be the aorta. So what are the indications to do transeptal puncture? Earlier it used to be diagnostic for hemodynamic assessment of valvular heart disease and to assess mitral and trans aortic gradients. And therapeutically, initially mitral valvuloplasty, access to the left-sided axillary pathways, transcatheter mitral valve repair and replacements, paravalvular leak closures, pulmonary vein isolations, percutaneous LV assisted devices, and left atrial appendage occlusions. And only absolute contraindications already discussed is the absolute presence of a free thrombus in left atrium and left atrial appendage. And relative contraindications are distorted anatomy. This usually happens, suppose if there is any kyphoscoliosis or any distended huge left atrium or dilated aortic root, etc., there where the anatomy will be distorted. Again, post-ASD surgical closures, post-ASD surgical repair. But of course, we had done 2 or 3 cases after post-ASD surgical closure, mitral stenosis. We ruptured the patch and we did a mitral valvotomy. Interrupted IVC is one thing where we cannot really access the atrial RA. So already discussed what are the steps to do on transeptal puncture. Initial access through femoral venous and arterial access. Entry into the superior vena cava and left innominate vein already discussed, because once you enter the left innominate vein, you can easily swipe through the intra-atrial septum, you can easily fall into the fossa ovalis. Place a pigtail catheter in the non-coronary sinus of the aortic sinus, because it gives a landmark, because this is the most posterior aspect and the most lowermost part of the aorta, and just behind that will be the fossa ovalis. And if you watch the descent of the catheter from the superior innominate into the fossa ovalis, it follows usually 3 steps. My first step will be from superior vena cava to right atrium. Again, the catheter will show another dip crossing the aortic mold, and third dip will be into the fossa ovalis. And confirm LA entry and estimate the LA size. I'll show you how to confirm the LA entry and how to estimate the LA size. And once you puncture, advance the sheath into the LA, and subsequent dilatation and rest of the procedures can be completed after this. So what are the tools for transeptal puncture? Already my colleague discussed. Is the transeptal needles. What we use regularly is a Mullin's sheath, fixed curve. But again, with the EP guys, they use the steerable sheaths like Esli sheaths. And for us to address different morphologies like dilated atria, left atrium, or different morphologies, probably we need to curve the fixed curve needles to get the proper results. Transeptal needles, the routinely used is broken burrow needle, which is marketed through the Medtronic, and nowadays they are not marketing in a proper way. And what we are using routinely is BRK needles of St. Jude. No, it's not about it, it's St. Jude. And another latest developments are NRG transeptal needles, etc. It is basically used for radio frequency ablation. So broken burrow needles, they will be having 3 parts. One is the inner wire, and outer one is the needle sheath, and the inner one is a broken burrow needle. And these are the different BRK needles. XS is these are the side views. XS will be having a steeper view, and BRK will be having a relatively sharper bevel angle. And these are the tools used for here. You can see this is the connector, and this will always be pointed in one direction, and the direction of which it always correlates with the direction of the tip of the needle. So if the direction is the direction of the tip corresponds to the direction of this angle. So 3 movements we already discussed. First from the IVC SVC to RA, and second is from over the limbus to the right atrium, and third into the abrupt movement into the fossa ovalis. You can see the anatomy here. See, I told you the connector direction. If you keep the connecting the direction in the 5 o'clock position, it will align perpendicular to the fossa ovalis. So once you descend from the SVC, reach the second through the aortic mold, and once you enter the fossa ovalis, your needle direction will automatically change from 3 o'clock to, once it falls into the fossa ovalis, the needle direction automatically falls from 3 o'clock to 5 o'clock position. And one location does not fit all. Most of the times we may puncture outside the fossa ovalis at times, but still the advantage is still in the part of the atrium. But difficulty by puncturing the outside the fossa ovalis is will be crossing the much thicker septum. Needle may not penetrate properly and difficult to assemble, advance the assembly, entire assembly and balloon. And sheaths may buckle and difficulty in controlling the subsequent catheters. So always, whenever you're doing transeptal punctures, make sure that you puncture the fossa ovalis. And engagement of the septum, we already discussed. And coming to the LA position of the tip, how do you confirm that you are in LA? One is, earlier days when we are in exams, the pressure, the broken burrow needle used to be connected to the pressure hemodynamic pressure monitor. So once it crosses the SVC and enters the right, it snugs the intrahiatal septum, the pressures used to get dampened. I'll show you the slide here. Here, this is how, once you're RA, you can see RA pressures, and once the needle snugs to the intrahiatal septum, there will be dampening of the pressures. And once the needle enters the LA, immediately the LA pressures, we can see directly LA pressures. That is how, this is one of the recommended methods by puncturing the LA, knowing the hemodynamic parameters. So we routinely follow, we descend the sheath in the anteroposterior view. See, we can see, if you see the anatomy, if you are directly descending from the SVC downwards, this is the aorta where we kept the pigtail catheter. Pigtail catheter will be the lowest non-coronary portion of this. Immediately below this will be the tricuspid valve. So keeping the catheter here will mark as a reference for us to puncture, because the fossa ovalis will be lying just below this at the level of the tricuspid. You have to draw an approximate horizontal line from below the level of the pigtail catheter to the posterior border, posterior LA border. In the middle line, roughly about 1 to 2 centimeters below the middle of the line, there lies the fossa ovalis. So this is an arbitrary line where we have to make sure that this is a fossa ovalis area in the AP view. So in the AP you can see this diagram. Below the aorta, there will be tricuspid valve, and the position comes like this. And coming to the lateral view, once you feel that we are entered the fossa ovalis area, immediately routine practice is to go to the lateral view, left lateral view, which is routinely taught and what we practice. So this is the line diagram of the left lateral view. Here, if you draw an arbitrary line from the pigtail catheter to the posterior margin of the heart at the level of the diaphragm, the fossa ovalis lies between the mid third and the lower third, the most posterior aspect. So this is the intrahiatal septum. The advantage in the left lateral view is the needle lies almost perpendicular to the intrahiatal septum in this view. So if you can reach the most posterior aspect, and roughly at the junction of the middle to the lower 1/3 of the distance between the aorta and the posterior cardiac margin, that is the area of the fossa ovalis. We usually cross the mitral valve at the in RAO view, because in the RAO view the mitral valve will be tricuspid valve will be almost coaxial to each other, side by side to each other, and the aorta and mitral valve entry will be almost parallel to each other. So which will help us by keeping a pigtail catheter in the LV, and by taking the help of the pigtail catheter, we can make it as a unit, make a direction to enter the mitral valve level, because in this RA view both of them lie parallel, that aortic valve entry and mitral valve entry. And in the LAO view, the fossa ovalis will be perpendicular, the entry will be perpendicular to the LAO view or left lateral view. So these are the line diagrams where you can see in the RA view both LA and LV will be overlapped, and in a LA or lateral view, the fossa ovalis will be perpendicular, and you can make an entry through the LAO view or left lateral view. Again, the diagram showing in the LAO view how to enter the fossa ovalis. Again, this diagram shows in the left lateral view where to puncture. It is almost like the posterior 1/3 to mid 1/3. You have to direct your needle and puncture here. And the position of the left atrium can be confirmed by, one is pressure tracing. You show immediately the left atrial pressures. Left atrial pressures will be relatively higher compared to right atrium, and will be having a large V waves, which confirms that it's in the left atrium. Immediately the saturations increase with the bright blood, And the position, if you check in the lateral, it will be in the most posterior position once you enter the LA. And the position can be confirmed by contrast injection in the lateral view. And another important landmark is left main bronchus. Left main bronchus always forms the roof of the left atrium. So if your catheter is crossing, going beyond or far above the left main bronchus, it means that you are not into left atrium. So it will never cross the left main bronchus. Again, this is another method I already told you, going the puncture by hemodynamic tracings. Once the catheter, when the broken bone needle hits the intraatrial septum, there will be dampening of the pressures. And again, if it enters in the left atrium, there will be reappearance of the LA pressures. And another important method is described as probing the septum. Most of the times, fossa ovalis is a very thin area. And senior operators have shown the entering the left atrium with very much successful rates without using a broken burrow needle, just by probing with the tip of the sheath in the fossa ovalis, because many of the times this will be having a flap-like ASD. So by just probing, 90% of the times there are papers published by Krishnamurthy et al. Where they have shown that without using the needle, just by probing the septum, they could enter the left atrium. And staining, because most of the times what we do is, once we hit the fossa ovalis, as a confirmation we give some contrast injection to see whether it's a septum or not. And this will give us an idea about the site of the puncture. Here, the two things to be mentioned here. One is, if you give a strain, if you give a contrast, suppose there is a vertical staining of the entire septum. It means that the septal needle is not coaxial, not at perpendicular to the septum. If there is a vertical staining, it means that needle is lying like this. So it is staining the entire septum. So it means you are entering the intraatrial septum in an oblique direction. You are dissecting the entire intraatrial septum. If you give a stain, if you give a contrast, it should produce a horizontal stain. If it produces a horizontal stain, it gives us an indication that we are perpendicular to the intraatrial septum, and that is the ideal site where to puncture. If it all, so you have to observe the configuration of the staining also while entering the septum. And another important thing what one should not do, especially as Dr. Dash said, once you are descending from the SVC into the RA like that, once you are above the aorta, you can feel the pulsations of the aorta. So if you are feeling the pulsations of the aorta, you should never give an attempt to puncture, because keeping the pigtail catheter in the aortic root gives an idea that you are away from the aorta. So always as a beginners, because I was surprised Professor Dash does without keeping an arterial line also, because his expertise, he can do that. But still we cannot take a chance, because the keeping a pigtail catheter in the aorta will give a direction of the aorta, size of the aorta, and well as we move far away from the aorta, because we cannot take chance of puncturing the aorta, because Professor Dash has shown in his previous experience there where inadvertently aorta got punctured while attempting to puncture the fossa ovalis. And such situations, suppose if the aorta is punctured, one should not be panicky, because once you check the pressures, you get an aortic pressures. And suppose in such situations, if you remove the catheter, it will be a catastrophe. So once if you identify that you have not entered through the, you had not advanced sheath, it's well okay. It's just a needle puncture. You can just wait and watch, give some heparin reversal and just wait and watch. If you have inadvertently entered the aorta, don't be panicky, but just don't remove the sheath at all. If you remove the sheath, it will be catastrophic. Just remove the sheath. You have identified that it is entered into the aorta, just leave it like that. If you have a PDA device closure, close it with a PDA device closure. If you don't have any PDA device right now in the cath lab, inform surgeon and he'll take care of the rest of the things. But never remove. Once you confirm that you entered the aorta inadvertently, just keep the sheath like that, give a protomin reversal, contact surgeon. Ideal ways, if you have a device, immediately you can close as an acquired or ruptured sinus, RSOV. So the evaluation of the intraatrial septal puncture, transseptal punctures has gained more acceptance. Previously, our indication was only mitral valvulotomy, where entering the fossa ovalis, the job is over. But with expanding indications, we need to do site-specific puncture of the intraatrial septum. But how do you do a site-specific puncture of the intraatrial septum? Because the fluoro is a blinded procedure. you cannot do on a blinded procedure, you cannot do a site-specific punctures. And transthoracic esophageal echocardiography and intracardiac echocardiography will give us an estimate about these site-specific punctures. And the most commonly used modes which we use with the transesophageal echo is, one is bicaval view at aortic view as well as a horizontal view, 4 chamber. Here you can see at the 90 degrees, you can see a bicaval view, SVC and RVC, and you can see clearly a fossa ovalis. And suppose if you tilt the needle, suppose if you image at 45 degrees transesophageal echo, you can see the postero-superior aspect, that is the retroaortic part, and as well as the postero-inferior part. So suppose if you want to make a antero-superior puncture, you have to be close like this, and you have to puncture close to the aorta. And if you want to make a more posterior puncture, you have to enter the most posterior. By doing a 4 chamber view, you can estimate whether you are close to the mitral wall or away from the mitral wall. This is how you estimate, you take the help of transesophageal echocardiography and do a site specific puncture. And this is some of the areas. Suppose if this is the most superior posterior portion, this is recommended whenever you are contemplating a mitral clip or transcatheter mitral implantation or a medial paravalvular leak closure. You have to adapt a superior posterior puncture. And most superior anterior puncture, that is retroaortic punctures, have to be attempted whenever you are attempting a transeptal PFO closure. And posterior inferior and in anterior inferior especially, we need to do whenever you are contemplating mitral repairs, transaortic. So these are the different sites for transeptal puncture. And what are the complications of transeptal puncture? Several series got published, and many of the times the complication rate is not that dangerous. It's only around less than 1% in many of the series. So you don't have to be panicky for doing a transeptal punctures. Only thing is you have to understand the anatomy, both anatomy as well as the fluoroscopic anatomy, and the correlation is very, very important while doing the transeptal puncture. So coming to the complications of transeptal puncture, one is most important is pericardial effusion and tamponade, and the most common sites for the rupture are roof of the LA, because especially roof of the LA is very, very important, because whenever you are puncturing, LA roof is small, LA size is small, or if you are entering the LA with a jerk, it is very likely that it goes and hits the roof of the LA, posterior LA wall, left atrial appendage, SVC to SVC or IVC. This complication especially can happen while advancing the sheath, Mullin sheath. If you are keeping the broken burrow needle inside that without a stillet, if you are passing the broken burrow needle through the Mullin sheath without using a stillet, there is an every chance that this needle may go and hit the Mullin sheath and may create a rupture in the SVC or IVC. Again, rupture of the aorta, pulmonary vein perforation are also common, and air embolism. We had one case of massive air embolism, and persistent ASD after the procedure with the shunt. This especially in our Nizam's days, one case presented as a continuous murmur. Actually, I presented the case as a bedside, continuous murmur. The case was that patient PBMV was attempted. It's an unsuccessful PBMV, tight fibrotic mitral wall. After the procedure, the mitral wall did not yield. It's an unsuccessful PBMV, but the perforation site yielded, persisted, and because of the high LA pressures, it created a continuous turbulence across the atrial septum, and it presented as a continuous murmur. I presented that case when I was in DM days. So persistent ASD, transient ST elevation and vasovagals, and another interesting perforation site is stitch phenomenon, puncturing of the RA in the posterior wall, entering the pericardial space and re-entering the LA. This especially happens when there is a huge LA. When there is a huge LA, at times LA falls into the right atrium, and if you try to puncture, it inadvertently punctures the posterior part of the RA, enters the transverse sinus, pericardial space, re-enters the LA, and it can be, once you complete the procedure will be successful, patient will be comfortable, you will be shifting to the ward, and after 1 or 2 hours, patient suddenly lands in a cardiac tamponade. Immediately after the closed procedure, nothing will be there. But after 1 or 2 hours, the patient lands in a temperate. So this is, I will show you the diagram how a stitch phenomenon occurs. So this is a stitch phenomenon. Here, suppose inadvertently the needle enters, punctures the right atrium, enters the transverse sinus area, re-enters the LA, and this can happen. So it enters through the intraatrial septum, pericardial space, LA roof, and procedure will be over. And once the procedure is over, you can get a late tamponade. So what are the challenges? See, especially broken proto needles are fixed needles. Especially when because we have seen a lot of cases from morning. Different anatomies, suppose the LA is large, LA is suppose RARV dilatation. With the routine bends, we may not approach the intraatrial septum. Where as with like a coronary wire, we may have to do a primary curve and secondary curve to enter the fossa ovalis. So another important thing is intraatrial septal aneurysms. At times, this will be there, posing a difficulty in puncturing the intraatrial septum, because once you try to poke through the intraatrial septum, suddenly it will give away, and immediately the needle goes and hits somewhere in the posterior wall. So care needs to be taken, especially in these sort of patients, and especially we have to take an image guidance, especially with a transit figure or something like that, to overcome these problems. So coming to the new innovations or new developments of intraatrial septal puncture, transseptal puncture, radiofrequency transseptal puncture, where we use a radiofrequency current to puncture the site. And it is the Bailey's medical transseptal systems. Even now, India it's nowadays available, and many EP guys are using this. This is the Bailey's system of using for doing transseptal punctures. And this another safe sept needle system. It's nowadays, I think it's not available in India. It's a very atraumatic needle system, LA wire, which immediately, suppose you just enter the LA, and once you enter it, it will immediately give a large coil, and it will prevent the cardiac tamper and other perforating complications. And even now steerable needles are coming into the market. As of now, they are not available in India, where we can use the steerable needles to get a better result with less complications. Thank you.
Thank you very much, sir, for your extensive and elaborative talk on transseptal puncture and explaining the different techniques. Sir, what happens only when there is aortic staining, sir? Aortic sinus is staining, patient is stable. Can we reattempt again, or we should abandon the procedure? We can attempt or abandon?
Only staining you can reattempt, because you have not punctured. You just pierce the. Even if you punctured through the needle also, you need not be scared. You just remove, just wait and watch.
Okay.
It's a 21 gas puncture.
Yes, sir.
So just remove it.
Broken burrow needle tip is only 21.
We should not pass it.
Yeah, please.
Sir, you are speaking about stitch phenomena, sir. Sir, suppose we puncture a bit higher in the septum, and we have crossed, and when we injected, we are sure that the contrast is going into the LA. But before passing the sheath across the intraatrial septum, how can we tell that it has not crossed through a stitch, rather than it has crossed in the higher superior septum?
Yeah, it's very difficult. We need a thorough and a very detailed echo to be done.
Sir, is there any way to get, because freshers like me always will have fear whether we have stretched it, we have passed it through and through the
See, once you have an idea that you have probably entered through this thing, it's better to keep a device as if not a contact surgeon. We better not, if you identify this phenomenon on table, you better not to remove the sheath as such like that.
Sir,
but it's very difficult to identify.
Sir, but it's very difficult.
It is most of the times a surgical finding, because you subject the patient for surgery, and surgeon will be telling you, sir, you have hit the posterior wall and entered the pericardial space, entered like this.
Because when they tell the stitch phenomena treatment, they say don't remove the sheath. But yeah, before removing the sheath, how we will be knowing that it is
a good echocardiographer needs to be there to identify this phenomenon. Sir, any experience of dash, sir? No, if at all. Yeah, high puncture. Fine.
Thank you, sir.
We're not using that, and they say that's one way of compared to broken barrow needle, that is a safer needle. 014 by guide wire.
But instead of that, what happens is nowadays, when we are introducing transeptal puncture needle, we advance the needle. Actually, nobody does this in the West. So what they do is they pass a coronary guide wire. Safe step, as Dr. Vasant is telling, is a 014 guide wire. So a floppy guide wire parketh in the pulmonary vein, so you do not have the risk of prevention. The second thing is, we do a lot of these interventions quite blind. We do rely upon the fluoroscopic landmarks and all that. I think it is time for us, experience is always a good thing to have, but at the same time doing a transeptal puncture under ice guidance makes it quite easy and very controlled and confident. So why people need to learn it is because it has got varied applications, as you have told. And finally, what happens is, in our country everything we can reuse, and similarly an ice catheter also can be reused. So that's one way where we can do a much safer puncture for this one. It's so easy if we use an ice for that.
Sir, any
Yeah.
experience, sir, Dr. Ash, any experience with the T guided puncture, sir? Whether you practice any time?
But I've gone once to States. My friend there, I was helping him. So their whole team were there. Their their professor, there is a head of department of echocardiography, non-invasive cardiology was there. Whole 5-6 people are there around, and big machine, T machine there. So they do under T only. But we India, see, sir, one time, sir, the people came. EP people came, they usually come visit. NRI people, they visit. They want to go to left side. I was there with him. So he told like this, I punctured. She really was startled. What happened? He punctured. So they cannot do these things without tea or ice. But they told like this, I punctured septum. So,
See, Dr. Bhaskara sent some NRS to this center, sir, to learn transeptal puncture. Again, the problem with them is that they cannot go back and do blind punctures there.
yes.
And
So,
we are not tuned to use the gadgets here.
And most of the TE is done by the anesthetist.
Yes.
Conscious sedation or under sedation.
Yeah. T is always general anesthesia type of a thing.
Yes, yes.
Actually, in the West also they moved away from TE because to ice only, because TE is expensive, because manpower is the most costly thing. I am pretty certain that India is also no far behind. Yeah.
Live case started? Yeah. Oh. Sir, Dr. Padnam, are you able to hear, sir? Padnaman, sir.
Am I audible?
Yes, sir. Continue.
We have already made a puncture. We are trying to cross the mitral wall.
Sir.
Now it has slipped down, came into our right atrium. I need to do a puncture again.
So, yes, now we can.
On the heparin, I need to do a puncture. Okay, get.
So we can watch right from the beginning.
No, sir. Wire relevant. వెళ్ళు అడ్వాన్స్ మళ్ళీ పురకన్ బరో అన్నీ చేసుకోవాలి స్ట్రైట్ చేయమ్మా ఏపీకి వచ్చేసి ప్లీజ్ కమ్ టు ఏపీ అంత ఈజీగా వచ్చేస్తుంది చూసావా ఫంక్షన్లో ఓకే తీసేమ్మా వైర్ మెయింటైన్ చేసి తీసి సో మళ్ళీ ముల్లిన్ షీట్ ఇస్తావా యా So what, I don't know whether they have saved. What we did was we did a septal puncture. It looked a bit low. So When we tried crossing, what you saw, the balloon just slipped out of the septal puncture. This will load share. అది తీసుకోవాలి అమ్మ మళ్ళీ ఆ వైర్ ఇచ్చాము వైర్ లోపల 3-2 వైర్ ఉందా రెడీగా 3-2 వైర్ తీసుకో దీంట్లో వెళ్ళాము మా 3-2 వెళ్ళాలి కదా 3-2 వైర్ బ్రోకన్ అది వదిలేసాం మేము ఏమైంది చేసాను mag
assistant should be very much vigilant, sir.
Please take out the mag.
That's a say. No, not the suppose other operator,
Be
he
attentive,
should immediately
please.
inflate the distal balloon. Once he notices that the balloon is jumping out, he should inflate the distal balloon.
Okay. Now,
No, that assistant has
cannot do that.
only should tell he can't handle balloon.
Reactivity is
More observant than the fellow who is doing it. More observant than the
No, sir, it happens, sir. No, it is because a small space. There is the puncture site and a metal, really very small space. Come on.
get broken burrow, please. Yeah, keep flushing. Keep flushing now. మాది 3-way కాంట్రాస్ట్ అన్ని రెడీ చేసుకో అదే 3-way can you just keep saline on the flush in keep flushing okay now aspirate slow aspirate ఇక్కడ కింక్ అవుతుంది సార్ ఇక్కడ bubbles on me I love to flush
people who are
fine keep contrast and
what sir is saying is
get a
in this particular case if this kind of puncture is done even entry into LV will be difficult so better to go for a re-puncture which is an ideal location.
Actually, there are a lot of misconceptions which we need to apprehensions and misplaced apprehensions in our
move
mind.
the table up please
Puncture, what is there in the
yeah keep it like that move up table head end move up further yeah keep it like that please మా స్పైన్ కొంచెం భుజం అటుపక్క జరిపమ్మా అటు జరిపాడు భుజం అటుపక్క జరుపు కొద్దిగా అంత కాదు పర్లేదు అదే కొంచెం ఇటు మళ్ళీ ఫైన్ మళ్ళా క్రాస్ అయిపోయింది ఫైన్ కొంచెం సరే కీప్ ఇట్ స్ట్రైటర్ హియర్ కింక్ అవుతుందమ్మా కమ్ మళ్ళీ మూవ్ అప్ ప్లీజ్ టేబుల్ టువర్డ్స్ హెడ్
The patient is little like this.
Fix it, don't move now.
Yeah,
go lateral.
There is one more thing which Dr. Dash is telling. You need to make the patient lie properly and straight. If they are not very straight, then puncture becomes very tough.
No, just keep it like that. Move it headward. Towards the head, please. Raise the table up.
That's
Yes.
correction matter, sir.
Keep it like that.
Low puncture means you can't negotiate the balloon to metal loss. No, what, sir, I am telling you that in frontal view, see your Molinsis should remain to the right to spine or
Yes,
just
sir.
right body spine. It
Already
comes towards
వెళ్ళిపోయింది.
midline.
మన path
This
function
function
లోనే
low.
వెళ్ళిపోయింది.
In frontal view.
Okay, come to AP.
Now see AP now, the C.
See, actually, it entered through the previous
Yeah,
puncture
yes,
only.
that's
I
right,
didn't make a
always
puncture
said
at all.
AP.
But
This
it is a
this
bit
quite
low,
also.
so I'm not
Okay,
too
fine,
comfortable.
It might work. And that too, elevation should remain like this, not like this.
ఏం చేద్దాం ఇంకేం
Across. You do remove the dilator? I don't remove dilator.
Huh?
I don't remove dilator. I put through dilator.
ఎలా వేరే ఉన్నా flush.
Dilator because
So we have already taken the
Dilator will
gradient
give
and
a,
all, so I'm not
stability to the
repeating
sheath.
now. We have previously taken gradient and also we are just directly putting the LA wire now and taking the
you
bulb.
need not go, sir. Your sheets should not go. Your dilator enough. Dilator enough.
జాగ్రత్త మధ్య లోపల పెట్టుకో ఇట్లా తీసుకో ఎవరు బ్రింగ్ ఇట్ అది బయటకు వచ్చేస్తుంది అడ్వాన్స్ సరే
No, this is no HLIP. That is elevation.
ఇది డైలెటర్
So, LV is going through now?
సపోజ్ ఇట్ గోస్ ఇన్ టు ఎల్వి
Fluoro shows fluoro. See, this position not good. This wire position not good. So that is again low puncture. This position. Yes.
It's not taking the shape at all. See this? I'm trying more and
That's I'm telling you. That I'm telling you. From there we can know. Yes.
I'll leave it like that. Will not do dilatation and all, directly balloon the system.
See now, sir, it's going like this, low puncture.
We'll try for alternate loop.
It punctures floor of the left pattern. What is it? No. I'm not okay.
ఇది వేరే ఇంకోట సరే
No, sir, what
Holding
when pulling down
up at 60 degrees.
yeah, same
You have to give one tug on the wire.
daily legs.
No, then only it will slide. Okay, fine. Serious tug, news tug is going to be giving me.
Needle. Yes. Daily legs.
లేదు
Minimal.
పట్టుకోవాలి కరెక్ట్గా టగ్ టఫ్ కదా
Not matter. Symptom. No, no matter. No.
never gripped on the floor.
No. Not.
For this, no.
Reverse loop or make it hairpin. Give shape to it. See, there is catch. Catch.
We have already checked the gradient, so I am directly trying to enter the LV now. ఇందులో ఏదైనా పనికొస్తుంది ఆల్టర్నేట్ లుక్ ఎనీథింగ్ విల్ వర్క్ చూద్దాం వెళ్ళాలి లోపలికి ఇన్ఫ్లేట్ ప్లీజ్
You people have seen many balloons in your life.
ఇన్ఫ్లేట్
When you blow a balloon, what will happen? The whole balloon will inflate. Why I know a balloon only
port
proximal
లేదా
part is
ఇది?
inflating and subsequently distal part is inflating late? Anybody got this doubt?
ఇక్కడ ప్రాక్సిమల్ బెండ్ ఉంది ముందు వైర్
When you inflate, this is not double lumen, no? This is single lumen.
టిప్ లేదు
No,
పోర్ట్ లేదు ఇది టిప్ పోయింది
basically double layered. That's what I want. So actually, what happens? No, in this
లేదమ్మా,
balloon,
పోయింది చూడు బెండ్
it is a latex that is the main balloon. It will be sandwiched with a
లేదమ్మా.
nylon mesh. The nylon mesh in the distal part will be loosely woven, so that when you inflate it,
I don't know
well.
what to do.
The proximal one will be tightly woven, so that you have to give more pressure to inflate. That is the this is the balloon with same mechanism for the 40 years. There is one wonderful article published recently by, yeah. One article by that Jolton Puria, what is he did this? Jolton, he written his 40 years experience on Mitral PBMV. He says that there is lot of change in techniques. Only thing that didn't change is I know it wasn't. For 40 years, same technology. May that's okay.
రెండు మళ్ళీ ఐ కాంట్ కీప్ ఇట్ ఫర్ లాంగర్ ఫ్లషింగ్ నాకు ఇది ఇస్తా పని వెళ్ళే వైర్ నేను కొంచెం లూప్ పెంచుకుంటా ఈ లోపు వెళ్ళే వైర్ విత్ మెటల్ స్ట్రెచింగ్ రాడ్ కమ్ we have some issues with our mitral wires. All of them are not in good shape. Advance please. Advance. Better రావాలి వెళ్ళి మళ్ళీ ఇన్ఫ్లేట్ చేయాలి చేయమ్మా కొద్దిగా చాలు నో ఇన్ఫ్లేటెడ్ ప్లీజ్ ఇన్ఫ్లేటెడ్ కొద్దిగా ఇంకా ఇన్ఫ్లేట్ చేయాలి సార్ విషయం No, this is not good. Are you ready with stillet, please? కొంచెం ఇన్ఫ్లేట్ చేసి this is what happened. Okay. Keep it inflated only. Okay, ఇది వచ్చేస్తుంది ఫస్ట్ ఇంకా ఏమంటే బిగ్గర్ లూప్ ఇది బోయిస్ ఓకే అట్లాగే ఉన్నాను సొల్యూషన్ తీసుకో Are you ready with any stillet? That's blood flash. ఇది కూడా ప్రాథమికంగా వెళ్ళింది అది పోవద్దు కొద్దిగా ఇన్ఫ్లేట్ చేసి పెట్టమ్మా ప్లీజ్ ప్లీజ్ కీప్ ఇట్ ఇన్ఫ్లేటెడ్ అరే ఇది బెండ్ అయిపోయిందమ్మా బాగాలేదు It's not going in. All my loop is gone. not able to advance at all. పోవటమే లేదు లోపల, బెండ్ అవుతుంది అన్నీ బెండ్. What are you having? Huh? Where you get me a proper one? మళ్ళా జిలేబీ తీసుకొని ఇస్తే వెళ్ళేవారు. I am having issues with my LA wire. I don't have a proper LA wire. All of them are, I am not able to advance to the tip. విట్రొచ్చి టిప్లో ఉంది బయటకు. ఏమైనా వెళ్ళా తెప్పించావా లేదా? ఇన్ఫ్లెట్ ఇంకా అది లేదు, వేరే వెళ్ళాలి అంతే. చెప్తాను ఇన్ఫ్లెట్ చేయమ్మా, ఇన్ఫ్లెట్. ఇది కూడా పోవట్లేదు అసలు. మళ్ళీ ఏం సొల్యూషన్? అరే వచ్చేసింది మొత్తం డిఫ్లెక్షన్. I think we are in RV now. We are in RV. మళ్ళా వచ్చేసింది సొల్యూషన్. అది లేదమ్మా ఆర్వి. ఇన్ఫ్లేటెడ్ బలూన్ షుడ్ నాట్ కమ్. ఏది ప్రెషర్ అయినది? Is it RV pressures? అంతే కదా, ఇది RV pressure. లేదమ్మా అది RV pressure. ఓకే, get again your 3-2 wire. డైరెక్ట్గా 3-2 వెళ్ళదు కదా దీంట్లో. మామూలు మళ్ళీ తీసుకో. Please get me one proper LA wire. Otherwise I will not be able to do. మ్యాక్ తీసేయమ్మా, ఏపీకి వచ్చే. మళ్ళీ మూడోసారి చేయాలి. మీరు ఏం చేస్తుంది? అట్లా కొంచెం మెయింటైన్ చేయాలి. ఆర్ యూ రెడీ విత్ యువర్ మళ్ళా ముందు మళ్ళీ 3-2 తెచ్చుకోవాలి. ముందు ముల్లిన్ చేతి ముల్లిన్ షేత్, తర్వాత 3-2, మళ్ళా బ్రోకన్ బరో అన్నీ. These things are not going.
Padmanabhan, is the left atrium small in this patient? Or?
No, it is dilated. The problem I am having is mostly this LA wires. None of them, or I am not able to advance any one of those LA wires. Either they are distally problematic or proximally problematic. I am not able to take to the distal. See, all of them have some bends and all here. I don't know whether you are able to see. So this portion I am not able to take.
If I am right, there is as it becomes more and more floppy, the caliber of the wire is tapering down. So the soldering of the wire is not
broken. 3-2 ready.
This morning also we had the kinking of the LA wire. This is not giving support to the balloon, and wherever there is this, what is happening is now we should possibly. I think this is a problem of the overall quality of this one. Actually, we are using this. Dr. Dash, I think whenever we use the LA wire abroad, we don't use this, no? We use something from the Abbott. About, they are very good. They don't have this problem. Yes. For all the electrophysiological procedures, no, they have the LA wire from Abbott. That will not have all this problem. What is happening is you start to reduce the something, cut down the cost. You start doing BMVs at 20,000 and all that. That is going to. This is the result of all that. You start doing. You become Chinese. No, this is not Chinese. Vascular Innovations is Thailand. It's Thailand. Actually, they are very good company. No, Vascular Innovations, but actually they sold the company recently. Rajahmundry.
Just keep it first. Just keep it. ఒక్క ఎండ కూడా లేదు లేదమ్మా సరే ట్రై బయట పెట్టి తీసి లోపల అంటే తీరాం ఓకే సరే ట్రై చేస్తాం పెట్టి okay, come. Please come. Trying to make a different puncture also, it doesn't matter. What to do? Doesn't matter. Please. I wish to make a different puncture. Pigtail flush ready, petkoma. Flush flush. Awesome. Flush. Okay. Contrast. The contrast, yeah? Okay. కొంచెం పైకి మూవ్ చేయండి టేబుల్ హెడ్ అండ్ అవే ఫ్రమ్ మీ యా కీప్ ఇట్ కెన్ యూ గో lateral please? Be ready for contrast injections. కింకల్ లేకుండా చూసుకో.
Okay, Dr. Padmanabhan, you want to do a little higher puncture?
Maybe that's an idea, but it is all slipping into that only all the time.
Yeah.
Fix, please, don't move the table.
I think once he entered into the left ventricle.
That is right ventricle. Yes.
No, we thought we entered left ventricle once. No, Leda. LA, over the LA wire, your balloon has gone into the LV.
Test. Test.
It may be too high.
No, stay now. Wait. Test. నేను చేతు చెప్తానమ్మా తల్లి నేను చెప్తాను స్ట్రెయిన్ అవుతుంది కదా అక్కడ లేదు ఇందుకే వస్తుంది సొల్యూషన్. మళ్ళీ టెస్ట్, మంచి టెస్ట్.
Is there any ASD there?
AP, come to AP please. Don't move. What pressures you are getting please?
Septal puncture repeated, dilated and all.
మళ్ళీ టెస్ట్ సేమ్ పాత్ టెస్ట్. It's again through the old puncture only.
Yes, obviously.
Why don't you keep the dilator a little bit there and then put the wire directly into the LV?
I tried, it is not going.
Not the LA wire, some other wire.
Some other wire.
You can, because this, it did not, he tried but did not go.
Okay, get me the jalebi wire. Let us see.
Yeah, I think because pointing towards the mitral valve, the sheath is pointing towards the mitral valve. Once we put the left atrial wire, the orientation is getting changing.
Otherwise, maybe I can take a right coronary and
that's what we were thinking.
Right coronary
Judkins
and
right
thermo,
and then
thermo.
Judkins right and 035 thermo wire.
సరే పట్టుకోమా, జంక్షన్తో పట్టుకొని తీసుకురా.
Just like a VSD we can cross and then.
No sir. Please come sir, welcome.
Yeah. Once again, this is the LA wire. This is the LA wire. LA wire, it looks to be.
Thermo with right coronary unda.
Judkins right and then thermo wire and then we can try that.
Or balloon flotation catheter.
Yeah, it's a 9 French catheter. No? 8 French.
Before that, can you shape the stellate right?
Sir?
Shape the stellate and right.
Sir, stellate का ये problem है.
Pardon sir? No, sheath, Mullin sheath. Mullin sheath. Once you are there, you can do, can put an LA wire and then cut the balloon or whatever.
नहीं ना, खाली Mullin sheath ना, balloon नहीं ना.
Oh, balloon नहीं. अच्छा.
Because if you see the left atrial margin is just at the
of
the spine. So it doesn't seem to be very large. But you can see the LA flow, LA shadow in shadow. No? Yeah. Yeah, you can see the soldering there. Yeah. You have got you.
तो फिर अल्टरनेटिव लूप पे जा रहा है.
Wash it.
What will do say? Come to arrow view.
Arrow 20 please.
Can we see the fluoroscopy, please?
Okay, now.
और भी कराएंगे सर, और थोड़ा सा करेंगे ना.
No, I don't want to do.
Alternate sir.
No, I don't want to.
Regular only. Regular का स्पेस नहीं है सर इसमें. Alternative बन रहा ना. Alternative बन रहा सर.
Alternate puncture करना सर.
हाँ?
Sir, alternative. Otherwise, very difficult to.
वो हर बार उसमें ही जा रहा है सर.
No.
Flush.
So he wants to go and make a U bend, hairpin bend, and.
Pulmonary vein. Okay.
So should we puncture one more time? Otherwise.
Yeah, that is better. That is better. वो अंदर ही नहीं जा रहा सर, ये पूरा
जाएगा सर.
I don't know, I had lot of problems with all the stillets.
Dilator better, wire introducer better.
Sir, और better.
Wire introducer better.
नहीं जा रहा सर. वो सब ठीक नहीं है सर.
Still give one more still.
All problems. So many I've tried sir, half a dozen. None of them are okay. Either प्रॉक्सिमिलिटी नहीं है वहाँ हमारा वहाँ बेंड
You don't have new things not there?
नॉट ए सिंगल दैट इज द प्रॉब्लम बिन आस्किंग जैसे जो 8 लाया मंगाया वो भी खत्म हो गया वो नहीं जा रहा ना కొంచెం అపెక్స్ ఇట్ తీసుకురా టువర్డ్స్ అ స్టేబుల్ ప్లేస్ యా सम मोर वो लास्ट नहीं जा रहा सर वही प्रॉब्लम निकल जाता है ऐसा करे तो निकल जाता है
You can do sir. You can do this case. You come to one more time sir.
या
Huh?
हाँ नो इश्यूज
Going any more stiller there? No stiller guys?
इज द प्रॉब्लम सर
No stillets. That shuttling still not there. Don't work sir. You have to puncture one more time.
हाँ कर लेंगे ना सर
Stretching to the stretching to.
స్ట్రెచింగ్ ఎల్లెవర్ అది ఎల్లెవర్ అండ్ స్ట్రెచింగ్ ట్యూబ్ लोपल राड बैठे वहाँ वहीं रखना निकाल ही दो
नहीं आपको निकाल देंगे
अरे वायर बेटा
छोड़ दो you leave it.
वायर नहीं जाता ना सर वायर पहले रहता है ना सर want to take this loop or just take it out
No, sir will see.
Yeah, fluoro please.
हाँ ये भी अच्छा है सर ये ट्राई कर सकते बट स्टिल नो स्टिलेट इज गोइंग हाँ
No records.
फिर अल्टरनेटिव बन गया सर
So he has made a hairpin bend and then that's
Without
what
the
he
stillet you
wanted
want
to do.
enter
Yes, yes.
वैसा भी होता है सर वो है ओपन जैसे है देखो
You still don't have stillet. What can be done?
బాగుందా మాది అది అంతే
The problem is the stylet is not advancing through the balloon, I think. Am I right, Dr. Padmanabhan?
Yeah,
There's
none
a
of these
kink in the
stillets
sheath,
are
the
going
lumen of the
inside.
sheath.
I don't know. They are not reaching the tip.
Ah.
Whatever we have tried. Yeah, I say
Yeah.
This is LV or RV?
LV sir.
Are you sure?
Yes sir.
Go lateral भी go. Go quick lateral.
LV. LV ही रहेगा
No,
sir.
no, sir, no.
नहीं आसानी से गया तो RV
no,
रहता.
yeah.
Last time RV था.
No.
Yeah,
Actually, hairpin
RV,
bend only.
RV,
He
sir.
just made it and
RV.
allowed it to drop to the
You can
mitral.
see.
Yeah,
Yeah,
that's what he did.
contrast
RV.
contrast ఉందా वो RV सर प्रेशर देख सकते हैं ना
RV.
Yeah. Honestly,
स्टिलेट सब निकाल के प्रेशर देख सकते हैं वो आरवी से वो इतना एंटीरियर कहाँ सर है आरवी ही रहेगा
RV, total RV. Come up.
हाँ आ जाओ सर
No, frontal भी आ जा.
ये फिर
Puncture one more time. So, आजा frontal आजा.
But here it looks like it doesn't look like the RV only. No?
बेटर
Yeah.
है
Otherwise, you will damage the fracture apparatus.
So we can view once again a puncture by Dr. Dash.
We'll puncture one more time.
Yeah, we'll puncture one more time. Anybody wants to ask some questions? I think.
What is that?
Anybody wants to ask some questions?
यस सर नो प्रॉब्लम
I think it's a very interesting scenario where when there is already a septal puncture and there is already a rent, whatever you do, it is going through that. So,
1 hour almost
yeah, possibly one more way. No, but operator change.
almost close to 1 hour sir 50 minutes
We'll do that. We'll finish it. Go inside. Go inside. Go inside. Hey, दिखाओ यार.
పైన
So,
మనం
Dr. Srinivas, if we want to do a
Paina.
puncture in the presence of already an existing rent in the septum,
Close there.
so how do you fix the Mullin sheath? How do because for us to puncture at a different location, whenever you come, you drag down the Mullin sheath, it is just dropping across into the septal defect. So
कम कर
so how do you
बहुत ज़्यादा करवाएं बहुत ज़्यादा करें
different location and fix it, and that's what I think
ऐसे ही रहता है सर बट का
should be done.
वो लेंथ भी ज़्यादा रहता है बहुत कम कर देगा अपन
ठीक है होगा सर
It will once again come into the same thing. Pardon.
छोड़ दो आप छोड़िए
That's what we were suggesting. Yeah.
Hey, one that's yeah. I'm on floor.
Okay, go lateral view.
Yeah, okay.
Anybody can want to come, sister, come here. I'm sorry that there. Get it there. Get it there. It is radiating so much unnecessarily. What is the frame rate? How much? Frame rate? Frame rate कितना? Fluoro frame rate?
So there are multiple techniques, I think, which in the past people were trying to cross the uncrossable valve like this. So one is to use a
show me the don't move the
one is to use a Swan-Ganz catheter. Yeah.
No, not required. As a frontal view? Frontal view, aja.
So a lot of operators perform nowadays don't use the pigtail as the landmark.
Same place. Go lateral view. Puncturing the right. You broken one needle not good for you, sir. Go lateral view.
I don't know. D10 is.
Okay, come frontal view.
Yeah, that's what Ramaraju is. Yeah, he has punctured at a different location now.
Anywhere, sir.
Yeah, it is. No, it is different. Previously, it fell down. It was little lower.
You're not going. This uses where, sir?
Definitely in the left atrium only. And
it doesn't loop at all. It is stiff, that junction.
this is a good loop. Yeah.
Dilator.
Good loop also. The way how the loop is.
नीचे का ग्राइंड का नहीं है
Septal. Get the balloon here.
balloon తెచ్చుకోండి
Decompression of the LV.
No, see, some other still will take. Okay, fine. Get the where?
No, PAH nowadays they are doing no
Just-
intratrial shunting.
No, but be careful. No. Hold on. Balloon लेके रहा. Balloon clean it, please. Balloon clean. No, what is that? No blood. Okay, clean. Sir, still it नहीं sir. ज़्यादा still नहीं क्या आपके पास? Hold on, man.
Yeah.
No, that's चलो.
Yeah, he had to do from the beginning he has been saying that we have to do another
So next
puncture.
life is not possible. Sir. Holding, sir.
ఏవో అన్ని బెండ్ ఉన్నాయి
Oh, not gone. Oh, gone, no?
Gone, sir.
नीचे सर नहीं छोड़ दो मारे हाँ no going yes holding sir this new place new one no bus no
స్టిల్ లెటర్ में
Chill.
go to arrow dear
20 hour
So what was? It's a different puncture. It's a
give
different
me the
puncture.
steroid please
Sometimes you can. This case illustrates that you
Sir,
can
Sunita,
do away with two important steps which we had been discussing at length. No, yes, already is crossed.
पंक्चर तो अच्छा है बढ़िया ऊपर नहीं
good.
लगा
useless you steroid useless sir oh
Already
my
crossed.
god
निकल जाएगा सर वो ये जो
Cross the septum, brother.
without still let it jana.
But it is actually it's
No,
across.
no.
It will cross. It will cross. But even this also looks quite a little lower than the normal.
Oh my God.
Another still let sir.
Yes.
Sir, you want to try this?
Yeah.
Balloon damage, I think.
What, Dr. Dash? What got damaged?
All wires.
Balloon got damaged, I think. They are still not
Yeah.
going.
So our Nostradamus was predicting this. Huh? Local Nostradamus. No, no.
Who is that?
Not going, sir.
All are like that, sir. I can know it.
No, sir.
चले जाए
हाँ, जो गिफ्ट
Cross.
सर
Yeah.
कर दो सर और एक बार अंदर
नहीं सर नहीं को डाल फुली
Yeah. Oh.
इलेक्ट्रिक दे
Congratulations. Yes.
एले पे सर
एल्ले प्रेशर
Patient space.
एल्वी भी देखें सर
Not patient.
देयर नो ड्रॉप इन एलवी एले आउट ऑफ प्रेशर सो नो एमआर
मत तो नहीं हुआ सर
Patient space.
नहीं सर मालूम नहीं नहीं निकल लीजिए
फ्लश है ना फ्लश वो कुत्ते
एल इज 0
Yeah. Yeah. Dr. Dash.
एल इज 0
LS 0. Oh, excellent.
मैं पिटेल डिस्टल सीरीज
लेट अस सी द एले हैमर्स
Huh?
ये भी जाएंगे सर
छोड़िए
पिटेल के भी जाएंगे
एक गोइंग टू हां सर वेयर ये जाएगा वेयर डू दैट वेयर
जाते हैं सर वायर जम पहले तो गए
नहीं सर ये सब हां ओके ओके टेक सर नो ग्रेड नो ग्रेडियंट
స్కేల్స్ మార్చమ్మా
नो ग्रेडियंट
200 కాదు స్కేల్స్ మార్చు 40 లో పెట్టు ఇంకా గ్రేడియంట్ మార్చు రెండు మార్చు ఫ్రెష్ ఏదమ్మా
ये नेगेटिव ग्रेडियंट
జీరో చేయాలా
just so nice look
always opened very well sir.
check MR the metal falling below the closer line MR check MR
ఎంఆర్ అమ్మా కలర్ है
no MR
सर ఎంఆర్ थोड़ा सा
you to hoga sir you to break definitely have some there no here no gradient sir see no gradient
ये तो बढ़िया है सर रिवर्स करिए
gradient sir
जीरो जेरा सर प्रेशर्स
what grad see that how much mean got 3 or 2 something will come how much mean 6 gradient that's fine that's prosthetic wall also so
निकाल ले एक मिनट सर जीरो कर
सर फिर जाएंगे तो एक बार जाएंगे दिस मच
हाँ बस है ना सर वो तो नहीं ग्रेडियंट फाइनल रिकॉर्डिंग कर रहे हैं सर वो ड्रिफ्ट हो गया जस्ट
make zero both make zero both
672
Dr. Dash.
हाँ जी
So.
no what I have done see that needle is not ideal needle that is needle for EP needle only that needle for the not for the BMV
Okay.
so you set the needle so you can able to puncture the second side
Okay. Okay. So you shape the needle by giving a more of a long bend. Long bend.
Release the curve so this is guarding this gradient L is 1312 only
Can we have a look at
huh?
Dr. Dash? Can we have a look at the needle, please? TSP needle.
So them needle
बाद में करना है
बाद में बहुत okay so that
We will
So
show
we
you one
wanted to
series,
see
sir.
what trick you adopted.
He reduced the curve quite a bit
He reduced the. Okay, he made it straighter.
yeah almost
Okay.
इनका लागे मत किन लागे
So you want to puncture it above, so you made it less.
that's fine
That's what. If you want to do a little lower puncture, then make it a larger curve.
अरे नहीं because sometimes what happen that will get tamponade or some cases not tamponade. अच्छा where is it? No, we are giving seat here.
no we are just comparing
Then
So what are the tips you, Dr. Dash, for crossing the valve? What was the trick what we used? We need your microphone.
No,
your
nothing. No, you didn't give any say. You went as such.
microphone, sir. Can you please use the microphone, sir? Just to your left, it is there.
Microphone.
They are not able to.
Sir, you have not done any shapes. You done it as it done, gone.
Okay, you punctured little higher up.
Yes.
And
So,
then you did not shape the stylet.
No.
Did you shape the stylet?
no.
So,
Didn't shape style it.
so we were curious to know. You did not perform a septal dilatation at
No.
a new site. Why?
You have dilated.
You dilated.
Yes.
So we did not see it.
Okay. Thank you.
You want to see this? You are able to see this?
Yeah.
The
Can you
reduced shape,
can
sir.
you show it to the blue one across the blue
So
background?
it was here. This is shape is.
Yeah.
Yes, sir.
Okay. You may. Okay.
It was too covered.
Thank you, Dr. Dash. Congratulations, Dr. Padmanabhan and Dr. Dash, for showing us a lot of very interesting case and lot of teaching points for all of us. Huge applause for Dr. Padmanabhan and Dr. Dash. Yeah.
After watching this complex intervention, now we are moving to the basics. It's a bedside teaching. I request Dr. Rajendra, DM resident from Narayana Medical College. He will be presenting the case. The clinical case is available, sir. I request Dr. Srinivas, sir, head of the department NIMS, and Dr. PK Das, sir, will join the presentation, sir. And we have here 4 DM residents are available, sir. I request all the residents to come forward. So they will have some good discussion. Please join. I request the resident to please introduce yourself to sir.
Good afternoon, sir. I am Dr. Varun. I am doing my DM cardiology second year from Katuri Medical College.
Good evening. I am Dr. Pavan, a second year resident from Dr. Pinnamne and Siddhartha, Vijayawada.
Good evening. Good evening, all my dignitaries. I myself, Dr. Rajendra, first year cardiology PG resident in Narayana Medical College. Here I am presenting a on case presentation. A 40 years old female homemaker resident of Ravulapalam came with chief complaint of shortness of breath in 6 months, palpitations in 6 months. History of present illness. Patient was apparently normal 6 months back. Shortness of breath started from since 6 months, insidious onset, gradually progressive. Initially it was presented with minimal NIHA class 2 with the climbing stairs of 2 flight of stairs and subsided with the rest. Since last 2 months, it was gradually progressive and difficulty in doing her regular activities like sweeping and washing the clothes, sweeping the floor and washing the clothes and relieved by taking rest. It progressed from NIHA class 2 to class 3. There is not associated with orthopnea and PND, no history of chest pain, nothing. History of palpitation since 2 months, which was intermittent and insidious onset and relieved by increased with exertion and relieved by taking rest. Not irregular, not associated with post palpitation diuresis, and no history of syncope, pedal edema, hemoptysis, no history of polyarthralgia, fever, no history of hoarseness of voice. History of 3 weekly deep IM injections from since 2002 to 2013. Past history. History of similar complaint started in the past during her second pregnancy at the 7th month of during second pregnancy at the age of her 19 years of age. Then she is having at that time severe breathlessness, doing even at rest, and orthopnea also present. She went to local hospital. From there, they given the water reducing pills and injections. Then they referred to KIMS Rajahmundry. From there she was diagnosed that she is having the valvular heart diseases. From since then up to 2002 to 2013 she was on medication and deeply three weekly IM injections as there. Now she is not associated with diabetes, hypertension and epilepsy, etc. Tuberculosis. Personal history, she takes mixed diet, not associated, bowel and bladder everything normal, micturition everything normal, and no relevant family history. She had 2 children at the age of, first child was at the age of 19, present is 22 years, second child was 20 years. At the age of second gravida, she is having the problem at the age of, at the time of 7th trimester, 7th month of the second pregnancy. She will have the initial complaints. And her socioeconomic status belongs to the poor, below the poverty line. This is the brief history of the patient. The positive findings are she was having not having any history of fever and no arthralgia, no migratory polyarthritis, nothing will be there. Initially she was started 39 years old and initial presenting symptoms are shortness of breath with orthopnea at the 7th month of second pregnancy, and she went to local hospital. They diagnosed as valvular heart diseases. From there onwards she was on, since up to 10 years of period, she was on 3 weekly deep IM injections and medications. Now she was comfortable with her life. Last since 6 months she is having breathlessness of class 3 NIHA, not associated with orthopnea and PND, and palpitations of irregular in nature and increased with strenuous exercises and relieved by taking rest, and not associated with postpartum diuresis. As per the history, my first probable diagnosis will be the acquired valvular heart disease, probably rheumatic etiology, because of 3 weekly injections, probably penicillin injections, and that may be mitral stenosis, my first possibility of diagnosis, as per the history.
Why is it not, why are you commenting on mitral stenosis? Why not? It is a regurgitant lesion.
Most common with the rheumatic heart disease is mitral stenosis. Mitral stenosis is more associated with the atrial fibrillation. Incidence is more.
Which is common? MS or MR is it atrial fibrillation?
MR.
MR. So,
yes.
Why MR?
LA dilatation is more with the MRs. MS. Pressures are more common with MS, sir. But dilatation will be volume overload condition is the MR. That's why MR is more dilatation of the LA will be there.
How do you differentiate? Because atrial fibrillation is not the thing.
Yes.
Differentiate between stenosis and regurgitation. What way do you consider stenosis?
And slow progression, sir. Since 20 years of progression. MS. With associated with AF is 5 years to take. Compare with MR.
Any irrigational lesion. Yes. Once patient becomes symptomatic, there is sharp decline in functional class.
Yes.
So the patient symptomatic MR symptomatic because LV dysfunction.
Yes.
So it declines fast. So MR symptoms progressive. MA symptoms because of what? Not LV dysfunction, because of the pulmonary venous pressure high.
Yes.
So pulmonary vein can accommodate.
Yes.
It can accommodate. It has got some it is capacious.
Yes,
accommodate. So MS patient takes time to get symptoms.
Sure.
Any irrigational lesion, either
Yes.
MR, AR, whatever may be, once symptomatic,
LV function.
rapid decline in symptoms.
Sure.
So if it is short duration.
No, sir. History of since at her age of 19 years, initial disease was started, sir. It's a second pregnancy, at the 7th month of second pregnancy, symptoms were started.
So regarding history, presentation, history of present illness should be as much as possible in the words and language of the patient, as patient has told you. So better to avoid scientific words like orthopnea, PND or NYH, all that is at the time of summary, you have to use that.
Sure.
So how the symptoms have affected her daily life.
Yes, sir.
That should be put in the context of her life,
Yes,
her symptoms. If she is a worker, how is it affecting her daily work?
Yes, I explained, sir. Difficulty in sweeping a floor and everything in the history I included, sir.
So,
I told.
So you consider MS. So
Yes.
what Dr. Raghu was
First
asking,
possibility
why you
is
want-
MS, sir.
How
Second,
do you explain palpitations history with the mitral stenosis?
But
Can you explain or not? If so, how?
LA dilatation and stretch palpitation. Yes.
Palpitation.
Irregular palpitations not associated with the post palpitation diuresis, sir. And regular palpitations will be rhythmic problem.
Repeat the history of palpitations again. Is it related to exertion or non-exertional palpitations?
Palpitation since 3 months, sir. Intermittent, associated with exertion, relieved by spontaneously, irregular in nature, and not associated with the post palpitation diuresis, sir.
What do you mean by exertional and irregular?
At the time of exertion, she felt the palpitations, sir, and it was not an regular. Sometimes it was very high and sometimes it was low. She is having pulmonary arterial hypertension. Yes.
What sir is asking is, if it's atrial fibrillation, why is it the patient getting aggravated on exertion?
Exertion will leads more and more LV output, sir, and needs no. Reduce. So MS will. Yes.
No, atrial fibrillation, palpitations of atrial fibrillation, is it usually related to exertion? First tell me that.
Yes.
Is it usually related to exertion?
No,
or
sir.
is it a constant? If it's an uncontrolled fast ventricular rate, is it exertional or is
Sir,
both exertional non-exertional?
Usually it is not related to exertional, sir. It is episodic and it comes on and off symptoms. Okay, sir.
So you can have exertional palpitation even in atrial fibrillation. Patient is on heart rate controlling drugs, medicines, and that is taking care of the heart rate at rest. But on exertion, as sir is telling, still the heart rate can become fast, ventricular rate can become fast, and patient can have the symptom of palpitation. So patient may present to you with exertional palpitation. Usually the exertional palpitations are due to what kind of cause? Usually. Is it arrhythmic or is it
mostly
hemodynamic?
Arrhythmic, sir.
Is it arrhythmic or hemodynamic?
Arrhythmic.
Exertion.
Sir, AVN not. And WPW. Sinus. Yes. ABR. And sir, first year. First year.
Pavan, మీరు which year you are? Second year. మీరు? Second year.
Just
What?
Yeah.
What is catecholaminergic polymorphic VT? CPVT?
CP.
That
Yes.
is exertion related or?
Yes, sir. Long QT is also type 2 long QT, sir. Type auditory stimuli, sir.
So, but okay, see, arrhythmias can be exertion related, but what is the more common causes of palpitations on exertion? Is it hemodynamic or arrhythmic?
Yes, sir. Yes, sir.
So MR or AR or TR, they'll cause more of exertion related palpitations, not MS.
Volume overload. Yes.
So in MS, if the patient has exertion related palpitations, what could be the causes?
LV stretch, exertion.
Yes, no, sir told no, exertion can cause fast ventricular rate, otherwise controlled ventricular rate of atrial fibrillation. Patient may have exertional palpitation. Anything else?
Addition.
Associated MR?
Associated with MR and
Yeah. So,
volume.
Yes. She is a candidate for development of additional lesions.
Yes, sir.
There are no other additional lesions. Still can MS cause palpitations, not related to atrial fibrillation.
Very
Patient
unlikely.
has severe pulmonary arterial hypertension. I'm giving you a clue.
Then RVH hyper, very unlikely.
TR, hypertensive TR. Patient, so in MS, patient can have exertion palpitations due to hypertensive TR and exertion related fast ventricular rate of atrial fibrillation. Yes. And
that protective MS will cause reduce the.
If the patient develops severe pulmonary arterial hypertension, proportionately what will come down in symptoms?
Murmur will.
Symptoms.
Exertion.
Patient has developed severe PAH with MS. What classical symptoms of MS will come down? That's what sir is asking.
Reduce blood. Pulmonary venous hypertension will be reduced due to protective effect of pulmonary arterial hypertension.
So P and D episodes will come down. Okay,
P and D and orthopnea will reduce.
Orthopnea may come down. Okay. So,
that is more with RV dysfunction and volume overload conditions will have the. Yes. Yes.
So you think it is a MS because of long-standing history?
Long-standing. And one.
So the palpitations could be due to atrial fibrillation or development of new regurgitant lesions or development of TR, hypertensive TR due to pulmonary arterial hypertension. Or why not simply ASD? See, the cardinal signs of left heart failure are not there, symptoms are not there in this patient. Like
yes,
P and orthopnea is not there. Only
as per the exertion. But
very
since childhood ASD will start at the age of 12, very large ASD will be there. In pregnancy, she is having, especially in second trimester and 7th month of the second pregnancy, sir.
What did she have?
She at that time she has the severe breathlessness and severe cough, sir. Intolerable cough with breathlessness and orthopnea and also present there. Unlikely, sir. So, yes, sir, that's why.
See, even those symptoms are not very pathognomonic of heart failure. So, she has breathlessness and cough. That doesn't mean it is left ventricular failure.
Yes.
So, once symptoms are find out what are the congenital heart disease, valvular disease, mitral disease, or any aqua disease, scan it one by one.
See, because this patient has been on penicillin prophylaxis, he has considered rheumatic heart disease. Yeah, pardon? Yes, yes. Yes, yes, that's what. You see, it is rather overused in our country. So,
first pregnancy, second pregnancy was there only, sir. She started before 6th month, sir. She started 6th month of pregnancy, sir. Symptoms are started, and LV function. Oh, sorry. With as per the history,
How do you know LV function from the history?
there is no pedal edema, no ortho. At the time of pregnancy, orthopnea is there, sir. Yes.
We ask these people that they are more serious. These three people will ask. Yeah, that's
What are the diseases which are well tolerated during pregnancy, which are not well tolerated, according to at least this case?
yeah.
Yes, sir.
Pavan avaru meera cheppandi.
Which well tolerated, not well tolerated?
Not well
Where
tolerated.
pregnancy is absolutely contraindicated.
Coarctation of aorta, not well tolerated, sir.
And then which disease tolerates, which are not, you told now. Dr. Ramaraju used to tell us, before coming into DM, you're all red downward, most of you actually, for entrance or something. Only during DM, what more you learn is only echocardiogram.
No, sir.
And some procedures.
No, DM actually it is for your investigational work and evidence-based medicine. Evidence medicine they don't know in MD. Evidence-based medicine plus echo and cardiac arrest. Basic cardiac arrest. No, echo and fundamental cardiac arrest.
Okay, please answer Dr. Vasant's question.
Well tolerated, not well tolerated.
What lesions are well tolerated during pregnancy?
ASD, VSD, PDA are
All shunt lesions are
all
well
shunt lesions are
tolerated.
well tolerated, sir.
Severe
PH in the absence of severe. Yes. So severe. Yes. Yes. Well done.
Metal regurgitation. Then what else?
And severe AS is not well tolerated, sir. Tolerated.
AR is tolerated or not?
Mild AR is tolerated, sir. Severe AR.
All regurgitant lesion, most of the times are well tolerated.
Yes.
So what are not tolerated?
Severe all ASD, VSD with PAH, sir, and severe mitral stenosis, severe AS, and coarctation of aorta, and
No, that leads to the next question. What are absolute contraindications to pregnancy?
absolute coarctation, sir. One.
Not absolute contraindication. As you said, it is not well tolerated, agreed.
Eisenmenger syndrome and PD. Yes. Sir, what question? Question.
Then what else? And idiopathic PAH? Primary PAH or idiopathic PAH? Huh? Okay.
Yes.
So any other differential diagnosis you want to consider other than MS with some regurgitant lesion for this history?
And
that's what Ramaraju says.
cardiomyopathy, peripartum cardiomyopathy. Very.
No, do you?
Cardiomyopathies are very unlikely to associated with arrhythmias, sir. Palpitations.
Why not? If the patient has significant MR.
With a that directly VT at the. Yes, sir. Yes, sir.
Why are you so much fixated on arrhythmia here? We have told you that this could be exertion related. Yes. Exertion preparation may be due to MR or AR or TR. So cannot MR occur in DCMP?
Yes, sir. Dilated.
Dilated cardiomyopathy with MR can explain your palpitation.
Palpitations.
And LV dilatation itself can cause palpitations.
Yes, sir.
due to dilated cardiomyopathy. Anything else?
And
But do you
as per-
expect patient to be in a non-progressive functional state for some decades with dilated cardiomyopathy?
Heart failure, more maximum natural history was 5 to 8 years only, sir. Severe heart failure with
Unlikely.
nearly 20 years.
Also, there will be punctuations of heart failure and admissions for heart failure. Huh?
Yes, sir. Repeated.
So, unlikely to be DCM.
Yes.
Anything else?
Congenital is unlikely, sir.
Why not? That's what we said. No, ASD is very much strongly possible here. Forget about the history of pendicular prophylaxis. Then everything fits with ASD. Why not Epstein's anomaly? Exertional palpitations and breathlessness. I said it's Epstein's anomaly.
Yes. Epstein's.
No, she doesn't have P and orthopnea, sir. No, he didn't say. No P and orthopnea. No, severe breathlessness, that's all. No P and as such. We should consider that. Yeah.
Yes.
What else would you consider?
Yeah. Myocarditis unlikely, sir. Infectious unlikely, sir.
HOCM? Long history of exertional breathlessness and no palpitations.
No palpitation and no history of diabetes, hypertension also she is not having.
Is HOCM possible with this history? No, not necessarily. There can be sporadic HOCM also. See, exertional breathlessness, that is the patient's main complaint. Isn't it so?
Dyspnea, angina and syncopal attacks will be more with HOCM, sir. But that symptoms are not present.
You see, each patient need not have all the symptoms of that particular lesion.
Yes.
The most common symptom of HOCM is exertional
breathlessness.
So that she has. No palpitations may be because of MR developing now. Okay. So go to the examination.
Examination, sir. Patient conscious, coherent, moderately built and moderately nourished. Her BMI was 21.4. No pallor, cyanosis, clubbing, lymphadenopathy. No dysmorphic features. No signs of infective endocarditis. Her vitals are pulse rate 68 per minute, irregularly irregular, variable volume, normal character. All peripheral pulses are felt. Pulse deficit was 8 and vessel wall condition was normal, sir. And BP 130/70, all average of the 4 multiple readings.
I'm sorry, pulse, what is the pulse?
68 per minute, irregularly irregular, variable volume, sir, normal character, and all peripheral pulses are felt. Pulse deficit was 8.
So how did you find that out?
Sir, pulse, there is 2 methods are there, sir. One is
What is pulse deficit?
the different heartbeat, the difference between the heartbeat and pulse, sir.
Why should it be there?
By auscultating and palpating the
No,
pulse.
why should it be there?
All atrial fibrillation beats will not conducted to the LV, sir. That propagated to the pulse volume, sir. Why not? Heart sound.
No, you are confusing with concealed conduction and this one. What is your name? Geetika. Sneha. Why is that pulse deficit in AF?
Long.
Crank stall. So weaker contractions are not transmitted peripherally. Okay. So now how do you make that out?
Sir, there is two methods, sir. One is along with the auscultating the heartbeat and palpate the radial artery. The missed beat we calculate, sir. There is missed beat. The which beat we are not felt, we calculate that missed beats, sir. One person is available, we do like that, sir. And one person, only 2 persons are available. One calculate the 1 minute of heartbeat, one calculate the pulse rates.
Okay, so pulse deficit is 8.
8. Sir. Okay. And BP was 130. Sir, more and more pulse. That is not, LV is underfilled, sir. Heart 68, sir.
For atrial fibrillation, 68 is well controlled or slow ventricular rate?
Controlled ventricular rate. So she is on medication, that's why.
No, what is the range, definition of controlled ventricular rate, the range of heart rate?
70 to 90. No, sir.
So this is in fact a slow ventricular rate for atrial fibrillation, 68 is. Okay.
BP was 130/80, average of 4 readings, sir. And respiratory rate 16 per minute, abdominal, thoraco-abdominal type, temperature afebrile, SpO2 100 with room air saturation, sir. JVP is raised 12 centimeters, absent A waves with alternative X descent.
12 centimeters above what? In what angle of recline?
45 degrees of angle. 45 degrees of 45 degrees of angle, sir. From manubrium sterni to raised JVP is 12 centimeters, sir. Not there. Manubrium sterni to 1 reading and upper border of the visible upper raised, sir. 7 centimeters are from 12 minus manubrium sterni, 7 centimeters raised. 5 centimeters from the manubrium sterni and 7 centimeters are raised. How much? I didn't get you, sir. Pardon, sir, I didn't get you. 1.7 into 1 centimeter is 1 mm of Hg, sir. 1 centimeter is 1 mm of H2O, sir. That's converted into 1.7 into total centimeters is gives a mm of Hg, sir. That is mercury.
What is the conversion factor?
0.7.
0.7 into actual measured in centimeters. So how much is that?
So 12 into 0.7.
No, sir. He is saying 1 centimeter will be, his conversion is taking 12 centimeters.
12, sir. So 8.4. 8.4. 8 million. Sir. Upper. 4 to 6, sir. Sir. Yes.
No, tell about the wave pattern. Tell about the wave pattern.
Absent A waves with attenuated X descent and variable V waves are absent A waves are especially. Attenuated X descent will cause irregularly. There will irregular contractions will causes there will be underfilling of the SVC and will leads to X descent attenuations. X prime is due to C wave is due to bulging X prime. Atrial relaxation, sir.
X is due to what? X prime is due to what?
X prime is due to atrial relaxation, sir. X is due to
What? You tell. Tell about the X and X prime. Diastole.
atrial relaxation.
Annulus. Annulus due to RV contraction. Okay. And X is due to atrial relaxation.
So how can which attenuated which
No.
Even A is absent, X also is absent.
When not contract now relax, no.
Tricuspid, with severe PAH is having prominent A waves, sir, with tricuspid regurgitation. Prominent CV wave with psychopathy, prominent. Canon A waves are seen in complete heart block.
No, what are Canon waves? It is seen in complete heart block, but what are Canon waves?
Atria contracts against the closed tricuspid valve will produce the Canon A waves, sir.
So it can be seen in CHB, AVNRT, AVRT. Huh? Okay.
Inspection and palpation, sir. Chest is bilaterally symmetrical, no deformities. Apical impulse in fifth intercostal space, medial to midclavicular line. Tapping type of apical impulse. Apical diastolic thrill is present, sir. Parasternal heave, grade 3 parasternal heave is present.
No thrills.
Sir, no thrill. Apical diastolic thrill is present. Yes. Apical diastolic thrill is present. Parasternal heave, grade 3 parasternal heave. Palpable P2 is present in the left second intercostal space. No other pulsations are seen, sir.
Continue.
Percussion, left heart batteries correspond to the apex, right heart battery retrosternal, and fifth intercostal, right fifth intercostal liver dullness are present. Pulmonary artery dull node, I didn't done. Supposed to do, sir. The pulmonary artery dilatation will indicate the dull node, sir. Indicated. Pulmonary artery. Yes, sir.
Pulmonary artery dilatation does not indicate dull node. Dull node indicates pulmonary artery dilatation. Okay. So you have grade 3 by 3 heave, tapping apical impulse, diastolic thrill, and second space pulsations, palpable sound.
Sir, palpable P2, yes, sir. Palpable.
We don't know what is that. There is a palpable sound. Okay. Then?
No other pulsations.
No other thrills and no other palpable sounds.
Yes,
Auscultation.
S1 loud variable with AF, sir. S2, A2 normal, loud P2 narrow split variable, no S3, S4. Opening snap is present, narrow A2. S1 loud and variable, sir. Sir. Sir, cardiac cycles are narrow and short cycles will be there, sir. When narrow cycle will be there, there will be very less time to close the mitral valve, sir. When long cycle will be there, more time to close the mitral valve will produce the loud sounds. Yes, sir. There is more and more diastolic period will be there, sir. In long cycle, more diastolic period will be there, and it produces long distance to travel. It produces a long.
Do you want to reverse the answering? Short cycles produce a louder sound and the long cycles produce a softer sound. What are all the determinants of the intensity of the first heart sound?
Heart rate and position of the mitral valve.
Heart rate means lower heart rate will produce a louder sound?
No, sir. Narrow cycles and long cycles, sir.
That's what. No, even atrial fibrillation it happens.
Yes.
Same. Okay.
Yes, sir. Position of the mitral valve.
So integrity of the mitral apparatus and all that mitral LV contractility.
Yes, sir.
Okay.
And opening. Sir,
Constant first order.
One is very uniform.
Can the pulse become regular with atrial fibrillation in any condition?
Factor 2 is very unlikely, sir.
When can the heart rate become regular in atrial fibrillation?
AF with 2:1 conduction. So, AF with 2:1 conduction. Complete out.
So patient is in atrial fibrillation, you are following up, and
Complete out.
heart rate becomes regular and slow. What do you suspect? CHP. But to what? What would be the reason?
Yes, escape ventricular rhythm, sir.
What will the cause? Etiology. What was the patient? What do you look for?
Pulmonary.
What medicines taking?
Mitral annular calcification will cause medicine, beta blockers, degox, digitox, paroxysmal. Sir.
Sometimes diabetic also in atrial fibrillation. Earlier they used to do area ablation and put a pacemaker.
Yes.
All those things.
So answer should be like this. Actually, your answers I told, said this, I should look for the medicine reduction. You ask for the has gone undergone heavy ablation with the pacemaker implantation. Look for that. Good answer. Will good scoring.
Opening snap was present, narrow A2 OS gap, sir. Okay, sir. Low pitched rough mid diastolic murmur grade 3/4. Most highest point of audible at apex, no radiation, better heard with the bell of the stethoscope. Yes, sir. A2 normal, P2 loud, narrow split. Due to pulmonary arterial hypertension. Sir, sir. Loud P2, sir. A2 normal, sir. Loud P2 is present. No, split is not. Split is variable, sir. Increasing with inspiration and decreasing with expiration.
See, you are not getting what teachers are telling.
Sir.
Sir is objecting to your saying P2 is loud and
Yes,
narrow split. So P2 cannot be narrow split. It is A2 P2 split which should be narrow.
No. Yes.
Please get that point when we
Yes,
are saying.
System.
That could open snap. No, why do you say P2? That could open snap.
Now little, is there no opening snap?
Yes, sir.
Then what is the A2 voice input?
Narrow, 0 point, normally 0 point, narrow,
Is it narrow or
narrow, sir.
wide?
It is hard localized or it is hard all over the cardiac?
No, sir. Localize it to left fourth intercostal space.
Localized sound or a widely heard sound? You tell. Huh? No, tell all the characteristics of opening. Yeah. What are all the features of opening?
That is LA cross over the LV pressure cross over the LA pressure, sir. The time taken for LV pressure cross over the LA pressure is already over, sir. High LA pressure is there. Its crossover time of LA pressure over the LV is very little bit less time, sir. LA pressure cross over the LV pressure. It causes opening of the valve, sir. LA is high pressure, it opens the valve. No, sir. LA pressure crosses the LV.
No, tell me what I am asking. How do you say this is opening snap?
After, immediately after the second heart sound.
No, is it sharp sound,
Sh-
high pitched or low pitched?
Sharp and high pitched sound, sir.
Is widely heard or localized?
Localized at the left side.
It's a wide, sharp, wide, high pitched sound. How can it be localized? Only low pitched sound can be localized. Okay? It's widely heard. It's a sharp and high pitched sound.
Yes.
No, what Ramaraju is asking?
I'm asking, why not A to P2? Why do you think it is opening to P2?
So how, in other words, how do you differentiate a wide split A to P2 or S2 from a to B, A to OS?
I didn't get the questions. During inspiration, there will be.
You see, I tell you, this can be, no, please listen to me. This can be a real conundrum when you are examining, because ASD and MS can be mistaken, one can be mistaken for the other. When you have a RV dilatation and RV rotation, your tricuspid MDM may be at the apex. You may mistake it for a mitral MDM, and a wide split S2 of A2, ASD can be mistaken for an A to OS interval. Okay? This is a real problem. So now you have to differentiate whether it's a real A to OS or a wide split A to P2. So how do you do that?
Due respiratory variation, sir, with respiratory variation. Inspiration, there will be more A to P2 gap will be reduced, and during expiration it will be reduced, sir. During inspiration it will be extended more.
Very good. That is A to P2. What about A to OS?
And immediately, that's fixed, and after 40 milliseconds, immediately after.
A to OS, what is the effect of respiration A to OS?
Expiration.
Let them answer. Sir, let them answer. You are continuing them.
No, they are not answering at all. End of silent.
So what is the effect of respiration on A to OS? Huh? It doesn't change. Then effect of posture? Standing, what happens? Effect of posture or standing? What is the effect of standing on A to P2 versus A to OS?
Standing, there will be reduced. A to P2 interval is reduced, sir. Like venous effect. A to OS. A to P2 interval, sir.
A to P2 interval is reduced because of
Reduced LV outflow, reduced venous return and reduced outflow, sir.
What outflow? A to outflow?
Pul-
What outflow?
reduced venous return and reduced pulmonary outflow, sir. It causes early closure of the pulmonary valve and reduces the A to P2 interval.
A to P2 narrows. Narrows, sir.
Yes.
What happens to A to OS on standing?
Doesn't change.
No, what will happen to the blood coming to the left heart after standing?
It's also
Reduced. So when what happens to LA pressure?
reduce,
So when LA pressure is reduced, what will happen to A to OS interval?
increases,
Widens.
widen, it increases.
Initially, few beats, A to OS interval will widen on standing.
Yes.
But once tachycardia occurs because of standing, again that will also narrow. But the initial few beats is very important to differentiate A to P2 versus A
Yes,
to OS.
yes,
Okay.
yes.
And what else? How else do you differentiate A to P2 from A to OS?
Bystander.
Then you
Take
are
it.
able to make out three sounds. Then the last sound is OS.
Don't say last one, which one? The second three sounds they are saying, what are the sequence?
A to P2 OS.
Okay.
Sorry, sir.
What should know it?
Okay, so you have an A to OS in this patient, and you think it's a narrow A to OS interval. Okay? Describe other features.
Low pitched rough mid-diastolic murmur, grade 3 by 4 at apex, maximum point of auscultation, no radiation, better heard with the bell of the stethoscope, increased with expiration in left lateral position, no presystolic accentuation. Yes, sir. 3 by 4. Diastolic. 4. Now associated with thrill, sir.
So how do you grade diastolic murmur?
No, sir, actually, it's a problem with me because many people they come to me. So really, diastolic, there's no grading actually. I don't have.
This is not a universally accepted.
No, it is parliamentary. No, the grading is systolic parliamentary in that. There no
Diastolic murmur is supposed to be not functional. So once they are diastolic murmur, they have significance. So we, at least when we studied, there were no grading of diastolic.
There was no grading. Even though this particular grading is not, as Sari is saying, not accepted by everyone. But anyway, for the sake of discussion.
Yes. Sir, grade 1 slightly audible, sir. Grade 2 better audible without thrill. Grade 3 audible with thrill. Grade 4 slightly away from the audible. Away. Yes. In systolic heart sounds, grade 4 is associated with the thrill, sir. In diastolic, grade 3 with the thrills.
Forget about grading. So rough rumbling, please repeat the description of the murmur.
Low pitched rough rumbling mid-diastolic murmur, grade 3 by 4, maximum point at apex, no radiation, better heard with the bell of the stethoscope.
Best heard at the apex. What maximum point at apex? So you
Mitral
should say
area.
best heard at the apex. Localized to apex or best heard at the apex. Okay. Then in left lateral position with breath held in expiration with no
Presystolic accentuation.
Okay. Any other murmurs?
No, sir.
So this, is it reaching up to first heart sound or not? Is the murmur reaching up to first heart sound?
No, sir. No presystolic
so
accentuation.
Purely mid-diastolic murmur?
No, purely mid-diastolic murmur.
Long diastole.
Long diastole murmur indicates the duration of the murmur indicates severity.
We are not asking you theory, man.
Yes,
in this patient, what is happening in the long diastole?
Then AF will reduce this case.
So you know the theory, but you have not applied it on the patient. Have you seen? Have you people seen the patient?
Why are you asking this question? Why are you asking this question? What happens to long cycle? What happens to length of the
How does it help you to assess the severity?
Duration.
Even in long diastole, if you are able to hear a long diastolic murmur reaching up to the first heart sound, it means it is a severe mitral stenosis. In spite of the RR interval being long. So in a short RR interval, anyway, because of abbreviated or shortened diastole, you will have more gradient and murmur may occupy the whole length of the diastole. You don't decide the severity of mitral stenosis based on the length of the murmur in short diastole. You always decide the severity based on the length of the murmur in long diastole. That is what sir is. So have you seen for, anyway it is a 68 heart rate, sir. But not reaching, but you are saying
but not reaching the S1. Sir.
No, it's not reaching. Then if there is not reaching, where is the question of no presystolic accentuation? You understand? Is it reaching or not?
Not reaching.
Then why did you say there is no presystolic accentuation? Do you understand my point? When the murmur is reaching up to the first heart sound, then there can be presystolic accentuation or no presystolic accentuation.
O32 wire, brother. Doctor,
not reaching, sir, and no presystolic.
I wanted to know your names.
Of presystolic accentuation.
Both of you. Arun.
Continue.
Arun and Prashant. Kalyan. Arun and Kalyan. So we pass the O32 wire from the.
We will complete.
And final.
So if you go here, you will not be able to cross it. So whenever if you want.
Other systems, sir. Now,
Okay, give your diagnosis, complete diagnosis.
this is,
No, we will discuss. First, let me.
sir. This is a case of acquired valvular heart disease of rheumatic etiology, probably mitral
Says
stenosis.
chronic rheumatic
The
heart
This
disease.
is chronic rheumatic heart disease, probably severe mitral
Why
stenosis.
probably? Why probably? No, don't use unnecessary adjectives and words. Be very precise. So CRHD, severe mitral disease.
Severe mitral with
Mitral
pulmonary
stenosis.
hypertension.
No, no. Now you have to commit whether it is a pliable valve or not clinically.
Pliable valve, sir.
Okay, we'll discuss that. Okay, next.
With pulmonary hypertension with AF and
Is there pulmonary venous hypertension or not?
pulmonary venous, no PND and orthopnea.
You have to say PVH, then
with
PAH.
PH.
Okay. No, grade this PAH.
Grade, as per the grade 3 parasternal heave, it may be severe PH.
No, what about P2?
Loud P2, sir.
No, loud means, is it louder than A2 at pulmonary area only, or is it louder than A2 in the whole of the precardium, even at apex?
Louder than the A2 at the aortic area, sir.
Not aortic area. Second space.
Second.
Not at the apex. At apex, A2 is louder than P2.
Apex, P2 is louder, sir. Yes, sir.
Then everywhere P2 is louder than
Yeah,
A2. So P2 is banging.
Yes, sir.
Now you tell, what is the severity of PAH?
More than 50. Severe PH, more than 50.
More than?
50.
No, don't. How do you know more than 50 or 80? Don't give your values here. There is
Severe
PAH. that's
severe
all.
PH.
Clinically, you can say severe PAH.
PVH is chronic patient, sir. There will be no orthopnea PND, mild PVH. Mild.
So there can be
Mild P?
severe pulmonary venous hypertension without severe pulmonary arterial hypertension. But there cannot be severe pulmonary arterial hypertension with PVH in mitral stenosis. Okay, in left heart disease.
Yes, sir. So yes, sir.
Okay, complete the diagnosis.
And associated with AF, no signs of congestive heart failure and no evidence of infective endocarditis, belongs to NIHA class 2, sir. No pedal edema and
But what about elevated JVP?
acute
His pedal edema occurs if there is a venous hypertension in the
venous
lower
hypertension,
limbs.
yes.
But if there is venous hypertension in the neck, there will be elevated JVP.
yes, sir. With signs of
Please do not ignore your own JVP finding. Very important finding. It's a patient in congestive heart failure.
yes. Class 2.
Now you substantiate each component of your diagnosis.
This is at the age of middle age.
No. I am not bothered about CRHD component. Severe mitral stenosis.
Severe one is A2OS gap is very low, sir, and mid-diastolic murmur prolonged the
Because of narrow A2OS interval. Gap gas interval.
narrow A2OS interval and
Diastolic thrill.
diastolic thrill,
Before that you have a diastolic thrill
Yes.
and a long MDM.
loud P2, diastolic thrill, loud P2 with narrow A2OS gap interval, narrow A2OS interval and MDM.
See, please don't mix up. There are direct signs and indirect signs for anything.
Yes.
For the severity of MS here, the direct signs are diastolic thrill, length of the murmur, A2OS interval. The indirect signs are the evidence of severe pulmonary arterial hypertension in the form of grade 3 pulmonary arterial hypertension, palpable P2, and then loud P2. Okay?
Yes.
So you should have that mental classification, direct signs and indirect signs. And among the direct signs you have thrill. That is an unequivocal evidence of severe MS. Yes. In spite of low heart rate, bradycardia. Then
And Irregular pulse indicates AF, sir.
No, we are not talking about that. So severity, still we are at severity only.
With pulmonary arterial hypertension, parasternal heave.
No,
and
MS severity.
MS.
So why do you think MDM is only localized to mid-diastole if you have a severe mitral stenosis? What are the reasons for it? The short murmur here.
Pliable valve.
Huh? You are saying there is no murmur is not reaching up to first heart zone.
Yes, sir.
So late diastolic murmur is not there. Only mid diastolic is there. How can you say that when there is severe MS?
Pliable valve, early opening of the valve will.
So what is the heart rate here? 68.
68.
So what is the relation between the heart rate and the length of the murmur?
Long diastolic period will causes the sir, in bradycardia diastole phase will be more, sir. In more diastolic phase, there will be murmur will be reduced. Low cycle, short duration of murmur also indicates the severe MS.
But murmur may not be reaching up to first heart zone because of the low heart rate and a long diastolic filling periods. Okay, then anything else? So you said it's a pliable valve.
Yes.
Is it a pliable or
Pliable.
mobile?
Pliable.
Pliability is
Openings.
indicated by?
Sir, openings.
Openings. And what else? For instance, assuming this patient had a murmur reaching up to first heart zone, what would you expect the murmur to be like if it is a pliable valve? Do you expect a presystolic accentuation or not? Presystolic component is there. Will it be accentuation also?
Yes, sir.
In atrial fibrillation? In sinus rhythm, what is the mechanism for the presystolic accentuation?
In sinus rhythm, there is a raised LA pressure will causes murmur. Continuous opening of the valve will produce.
Veer Japan, why is there presystolic accentuation in sinus rhythm in severe MS? Contraction causes what? Further increases the transvalvular gradient, thereby increases the murmur intensity. So, can you expect presystolic accentuation in the presence of atrial fibrillation when the valve is pliable? Will it be lost or can it be still retained? It can be present. Why? What is the reason? So this is not the mechanism, obviously, because atrial contraction is not there, but still there can be presystolic accentuation. So LV starts contracting even before isovolumic, pre-isovolumic contraction phase of left ventricular contraction will occur. That will slowly start raising the LV pressures. If the mitral valve is pliable, that will start closing the mitral valve as well as the annulus also starts narrowing. So because of that, in spite of atrial fibrillation and loss of atrial kick, still there can be increase in the gradient and increase in the intensity of the murmur. Okay, so even in atrial fibrillation, you can have presystolic accentuation of the murmur, suggesting strongly a pliable mitral valve. Anything else?
And severe pulmonary hypertension with signs of congestive cardiac failure, no evidence of infective endocarditis, sir. She is not having history of fever and splinter hemorrhages, no organomegaly. Yes. Yes. Bilateral basal clefts also there, sir. Bilateral basal clefts also there on auscultation of the lungs. No, she is very less. Protective pulmonary arterial contraction will reduce the flow to the pulmonary veins and reduce the congestion of the lungs. Yes.
fluid can come out. That's a two mechanism there. One is this valvuloplasty membrane
Yes.
thickness because of the exudative fluid is more protein content, so that was a fibrosis. The valvuloplasty membrane thickened. So capillary fluid can enter to alveoli. One. Second is the hypertrophy of the lymphatics. Meaning there's no fluid, so lymphatics will run out. Okay? Then increase endothelin, local endothelin is increased. That is vasoconstriction. So that's why you won't get vessel creates long-standing congestion. Need metastasis or direct edema come to you. J periods but long set here.
Stop here, sir. We'll continue. Finish now? Okay, thank you.
Rajendra, sir.
Really appreciate you being a first year for your courage and taking initiative. Really congratulate Rajesh. Thank you.
Thank you, sir. Thank you, sir.
Very good. For the first year, your the presentation skills and your interpretation of the data is, yeah. No, not yeah. You took the opportunity of for presenting before two eminent professors, one from Nizam's Institute and one senior examiner, and who might have passed nearly more than how many hundreds of cardiologists, sir? Many. So many hundreds of cardiologists came through Professor Dash. You can shift to the live case. Raghu?
Yeah.
Yeah. Again low puncture? Yeah.
We don't know.
We have to alter the shape of the needle.
We went as per
Shape of the
the
needle needs to be
fluoroscopic
altered.
landmarks. Is it low or not, we have to see. Stylet. So this patient has a mitral valve, which is, she's a 55-year-old lady, so obviously not the usual age of balloon mitral valvotomy, what I personally prefer. And she has got a medial commissure which is free, and the lateral commissure has got a
We take this opportunity to honor Professor B. Srinivas for kindly accepting and coming to Rajahmundry.
pulmonary vein lone. Yeah. Now it is okay. So it is going up to the tip or no? No. Yeah. Yeah. Okay, go. Okay. Save.
Oh, wonderful.
So what we do is you give a little counter clock.
We take this opportunity to
this assembly
honor
so that it
our
drops
teacher,
and falls into
Dr.
the
T.N.C. Padmanabhan,
mitral valve.
who readily accepted to come over here because this happened to be one of our institutions in which he landed the seats here.
Counter clock the stylet.
Professor Dash, please.
The
మళ్ళీ కనెక్ట్ అది త్రీ వే ఇంకోటి ఇవ్వరా 10 సెంటీమీటర్ త్రీ వే కనెక్షన్.
So you make it clockwise. Save the fluoro. You make the run there. Fluoro save చేసినావా చేయలే. Longs fluoro ఉంది. Okay. So we were not crossing the valve. So So when it is pointing posteriorly, so you bring the pigtail loop anteriorly.
ఎలా ఉన్నావు విజయలక్ష్మి అయిపోయింది ఆపరేషన్
MRI అయితే లేదు. ఓకే 12 ఉందా? నో గ్రేడియంట్.
మీరు ఫ్లైట్లో తీసుకెళ్ళండి. క్యాబిన్ హ్యాండ్ బ్యాగేజ్ తీసుకెళ్ళండి.
వెరీ ఫేమస్.
హ్యాండ్ బ్యాగేజ్ ఎలా పట్టుకోండి.
Not much, I don't think it's okay. It's okay. Apical 4 chamber. So you can see the gradient is not there. And
what was the initial LA pressure?
LA pressure we did not check, no? So the steps would be to, when you puncture the septum, you puncture the septum at the, you have got the pigtail, you have got the posterior spine, this is the pigtail, this is the spine. You go point, don't point here, don't point towards the, something like, I don't know, 1 o'clock, 2 o'clock, go in, then you give a little clockwise so that,
Lateral commissure split well.
yeah.
That is the one what we had.
Yeah, because the calcium is on the mitral leaflet. No, that's not the valve area. Just allow it to run. Oh, sorry, then do it.
He used to enjoy my feeding.
Okay, I cannot. But definitely the lateral commissure has split open. You can see that.
Some to pass long acting, what we properly did is, some to pass long acting.
The mitral leaflet suppression. Okay, take this one. Lateral commissure open is that should be fine, I think. At 55, what is the point of wire advance? So then you lock this one here like this. Then you should not push it now. You have to pull it. You have to pull it and lock it. See how it got straightened. That's all. It's just these two steps are important. When you introduce, yeah. So when you introduce, you push. When you withdraw, when you remove, yeah, pull back the sheet. If you do not lock it, then the gets spoiled. Then when you should not without the wire and
వెయిట్ చేస్తున్నారు ప్రణవ్ వాడు ఇంటికి వెళ్దాం ఇంటికి కాకినాడ
Thank you.
Very, very happy to see you.
నిజంగా అసలు అది ఎక్స్పీరియన్స్. కన్సల్టేషన్ ఉన్నాయంటే ఏమన్నా మార్వాడి ఏం పిలుస్తుంటాడు ఏంటి అడిగిన బయటికి పోయాడు. మార్వాడి కన్సల్టేషన్ ఉందేమో చూడండి.
We'll conclude the session here, and I request all the delegates to join for the dinner in Hotel Shelton. మీరేదో కేసు ప్లాన్ చేస్తున్నారట.
చూపిద్దామని కొద్దిగా సీరియస్.